Lovely, thank you. Yes, so as Hayden's kindly introduced, I'm Katie Lewis. I'm the Paediatric Service Manager covering both the North Yorkshire service, SARC service, and the West Yorkshire service. I've been in post now just over 18 months for Mountain Healthcare. So just a bit of a background really about CSA. I apologise if people already know this information, but I thought giving a bit of a definition and an overview of some statistics might help kind of people understand the importance of our SARC services for the children of North Yorkshire. So if I've taken this definition from the Working Together to Safeguard Children document, which identifies child sexual abuse as either forcing or enticing a child or young person to take part in a sexual activity, which doesn't necessarily involve a high level of violence, and whether the child is aware of what's happening or not. Activities may involve physical contact, including assault by penetration, for example, or non-penetrative acts. It involves kissing, rubbing, touching, whether that's outside or inside of clothing. And it also includes non-contact activities such as involving children at looking at or being in the production of sexual images or videos, or encouraging children to behave in a sexually inappropriate way and grooming a child. Sexual abuse can take place online, with technology being used to facilitate offline abuse. And sexual abuse is not solely perpetrated by adult males. Women and other children could also commit acts of sexual abuse. And we certainly see kind of all the examples given there coming through the paediatric SARC services. We get disclosures of a range of assaults, which varies dramatically from rape and penetration all the way to touching inside and outside of clothing. So we see that everything on that spectrum that the definition of CSA covers. And looking at the statistics, so the statistics I've taken from the new Tackling Child Sexual Abuse Strategy 2021. So we're looking at these statistics are really recent, covering kind of 2019, 2020. And the document says that it's an estimated that 3.1 million people have experienced child sexual abuse in England and Wales, which equates to around 700,000 men and 2.4 million women. And that's approximately 5% of boys and 15% of girls. And again, just a couple more statistics that I thought were poignant. So overall, we've seen a steep increase in the reporting of child sexual abuse to the police, with over 83,000 child sexual abuse offences reported to the police by the year ending March 2020, which is an increase of approximately 267% since 2013, which I couldn't believe it when I saw that statistic. It was a massive increase, but also reassuring that more people are coming forward and reporting abuse and making those disclosures. Of around 58,000 would be considered contact offences, which have increased by 202% within the same period. And it's interesting to note that these figures don't just capture all sexual offences. So they don't include certain sexual offences committed against 16 and 17-year-olds, such as rape, and it doesn't cover sexual assault against children over the age of 13. So the actual figures are probably likely to be much higher. And in contrast, there were 5,116 charges. So from the disclosures that were reported, there were just over 5,000 charges for child sex offences in the year ending March 2020. And in April 2020, the NCA, the National Crime Agency, estimated that a minimum of approximately 300,000 individuals in the UK pose a sexual threat to children, either that's through contact abuse or online. And this is just pulling all that information into a graph. So that's just showing how what a steep increase the reporting of abuse have taken over the current years, previous years. And although we're starting to see a bit of a downward dip more recently, we're nowhere near kind of 2005, 2006 figures. Reporting CSA. So the majority of child sexual abuse remains hidden and under-identified. In many cases, victims and survivors disclose the abuse they have suffered decades later. And it's estimated that 67% of adults who experienced rape or assault by penetration as children didn't tell anybody about their experience at the time. Non-recent cases, which is where the abuse has occurred 12 or more months prior to it being reported, accounted for about 34% of all sexual offences against children that were reported by the police in the year ending March 2019. And this just categorises the reasons for not disclosing, which I find is a really interesting graph. So 50% of the of adults who experienced childhood sexual abuse didn't want to disclose because of embarrassment. 44% didn't think that they'd be believed. 29% thought it would be humiliating. 21% didn't think anyone would do anything about it. 18% feared that more violence would come as a result of telling people. 17% didn't think they would get a sympathetic response. 16% didn't have anybody to tell or didn't feel they had anybody to tell. And 12% felt that it was a private or family matter and should be kept that way within the family. And I think for me, my personal view when I look at that and kind of working in the SARC world is that by having a discussion with a child or young person or the family about accessing the SARC service, that we can work to dispel the majority, if not all, of those myths or those thoughts that somebody might have. If they come to a SARC, the message is to them that they are believed, that somebody is listening, that they have got a sympathetic ear with the SARC staff and other professionals in the wider community, and we can work with them to kind of quash their feelings of embarrassment and their feelings of humiliation, and work with them to make sure that they feel believed and valued, and that they are referred on to more longer term support services. So moving on to Mountain Healthcare, who are the provider of the Paediatric SARC services in North Yorkshire. So Mountain Healthcare is the largest SARC provider in the UK, and we've provided a paediatric service in West Yorkshire since 2016, and then the North Yorkshire service more recently since 2020. The North Yorkshire paediatric service is made up of a doctor or a nurse-led service, and a crisis worker that acts as a support worker. So if a child comes to the SARC and they're under 13 or they've made a disclosure of non-recent abuse, they'll be supported by a doctor and a crisis worker. And for the older children who are 13 and over and have made a disclosure of acute abuse, they'll be supported by a nurse and a crisis worker. And we can support patients from 0 up to and including 15 years. We offer a community-based STI follow-up service, and like I say, we offer both an acute and a non-recent clinic. We've also recently, within the last 6 months, employed a strategy coordinator. So she works across both our West Yorkshire and our North Yorkshire service, and she's kind of our gateway to the services, and triages and gets our children booked into the services. So no matter which location in West Yorkshire and North Yorkshire, the time frame of abuse, Emily, our strategy coordinator, can help navigate that appointment and get them booked in, and make sure that the communication's given to kind of our internal staff and the referrers and external agencies as well. So a bit more about our service provision. Like I say, we offer both acute and a non-recent clinic. Our non-recent clinic is held 1 day per week, which is on a Friday at the minute. And within that, we're able to facilitate 2 appointments. Of course, if Fridays, aren't doable for the child family, there is some flexibility around that. We always try and put the child first. And referrals are made the following day unless they're extremely urgent. So they're referrals to onward support agencies from the SARC that the SARC professionals make. And paediatric reports are completed and shared with the allocated social worker, and our doctors have got a 3-week period in which to complete those medical reports and share them with SARC staff so we can get them out to the correct social workers. And we can support ongoing police and social care investigations. So who do we see and what do we do? What does a SARC appointment look like? So we don't just do forensics, although that is a big part of what we can and what we're able to offer. So if we've got an acute patient attending the SARC and they are within the time frames for forensic evidence to be gathered from them, we can offer to do that, and they will always be handed over to the police officer. We always ask for a professional to be in attendance at our appointments. So if it is a case that's an acute, if a patient has come to us and we've gathered DNA evidence, we ask that a police officer be in attendance so that we can hand over that evidence to them. In other cases, if it's a non-recent case, a non-recent patient, or an acute patient that doesn't need forensics taken, we ask that either a police officer or a social worker be in attendance, and then we can do our handovers face to face, and we can discuss safeguarding with people face to face, and that works very well. We also offer injury checks, and we document those on our body maps at the SARC. We also use a forensic camera so that we can video genital injuries and the examination. We offer STI screening, so we can offer an STI-based screening at the SARC appointment, and we can also offer a follow-up service, which is community-based. It wasn't community-based while the pandemic's kind of been ongoing, but we have just reintroduced that to the community. So our STI follow-up nurse is able to see patients within their own home or a safe space. Of course, we're having to do the COVID screening, and she's going out in full PPE now, but at least that's been reintroduced, so that's a big positive. We can offer HIV, Pep C and emergency contraception if our patients are in the time frame for those and it's appropriate. And we make referrals and we information share with a range of different agencies and professionals across the region. We'll always information share with social care if that child is known. If the child is not known, we'll always put a full referral into social care. We'll offer a CHISVA referral, so a child independent sexual violence advisor, and they can offer more long-term support to the child and the wider family, particularly if that case is going to go through the criminal justice system. We'll make referrals into the CAM service, CSE support, and to paediatricians and GPs and health visitors and school nurses, depending on our doctor's recommendations. And I just wanted to differentiate between what the SARC classes as an acute case and what the SARC classes as a non-recent case. So our acute cases are within a 14-day period, and there's different forensic timescales within that, but we will see a child, if they've made a disclosure of abuse that's happened within the last 14 days, they will always be classed as an acute case and come to us as an acute case. And within that appointment, an acute appointment, we would take forensic samples and hand those over to the police if that's required and they're within that forensic time frame. We would offer emergency contraception and HIV Pep C if it's appropriate. We can offer pregnancy testing if that's appropriate. We can discuss different options with the patient and the family if the test does come back positive. We offer a general examination and the documentation of injuries. And I'd just like to say and highlight that when we do that, we'd never ask a child to fully undress and clothe in front of us. It's done very slowly in a very step-by-step manner, so that the child only has to uncover a small part of themselves along the way. So you would document kind of arms, and then they'd cover their arms back up again, and then we'd move on to a different part, so they don't have to fully expose all the body at the same time. We would record the intimate area with a forensic camera, and we offer an holistic assessment. So we look at their wider kind of health and social needs. We'll look at if they are registered at a doctor, dentist, if the family's known to social care, if they're known to CAMS, and look at their physical and mental well-being, and kind of look to see where we can signpost or refer the child into long-term support. We can offer outward referrals, and we would offer either a medical report or a statement for the social worker in the case. So our non-recent appointments are slightly different due to the timescales. So again, we'd still offer a general examination, and we'd document any injuries found. We'd still offer pregnancy testing if it was appropriate, and we'd still discuss the options with the patient and family if the test is positive. We still make a recording of the intimate images if the child and the family's consenting. We still offer an holistic assessment and complete outward referrals, and the medical report or a statement would still be produced. So I wanted to document really what kind of the child and family and professional can expect when they're coming through to the SARC. So prior to a child accessing the SARC, we would have the child referred into us. So our pathways state that only a social worker or a police officer can make a referral into the SARC. However, we're encouraging all professionals, if they do have a concern, to give us a ring, and we can help guide that process, particularly with our STRAT coordinator. She's often kind of the missing puzzle piece between either a police officer and a social worker and the professional that's raised concerns. And the sooner we can know about a child, the better, and the quicker that child can get into the SARC, particularly if it's an acute forensic case. We don't want to delay a child accessing the SARC. So if you do have concerns, just give us a ring and we can help guide that process. We would also encourage a strategy discussion prior to a child attending the SARC if the forensic timescales permitting. And that really helps not just the SARC staff, but also all the professionals that are involved in the case decide between them if a SARC appointment is necessary. They get to understand what to expect within a SARC appointment, and it allows our doctors to start very early on coming up with a forensic strategy and to start formulating an idea of what SARC appointment's going to look like for that child, and start putting the puzzle pieces together of how they would like that appointment to run. All appointments are tailored to each individual child, so the sooner we can start determining what that appointment looks like, the more child-centred it can be, and the quicker the appointment is as well. So once it's agreed that the child's going to be attending the SARC, like I say, the family will attend with either a police officer or a social worker, and we would ask that the adult that holds parental responsibility for that child attends the appointments. If that's appropriate, it's not always appropriate, and we can gain consent over the phone. However, best practice is attend the SARC if possible. So each patient would be greeted by a crisis worker. Our crisis workers wear child-friendly scrubs. They're very bubbly and welcoming, and they'll support the professionals and the family into the SARC. The crisis worker will then spend the majority of their time with the child or the young person and act as their advocate and kind of handhold them through the entire SARC process. So they will constantly be checking in with the child, young person and the family to make sure that they are comfortable, to make sure that they continue to consent throughout the appointment. And if anything changes, if there's any changes in body language, verbal language, behaviour, they can relay that information back to the doctor and just act as that advocate for that young person. The doctor or the nurse will chat to the professionals present to determine what samples need to be taken, what kind of images need to be taken on our forensic camera, what's likely to be on a body map for documentation of injuries. So again, that's following through from the discussions within the strategy discussions, and the doctor can continue to kind of formulate a plan of what that forensic strategy looks like for this patient. So for the majority of the kind of the first half of the appointment, the crisis worker will keep the child or the young person company, depending on the age. They'll chat, they'll draw. We've got iPads, we've got toys, Lego. And the crisis worker will just keep them occupied, keep them busy, keep them chatting, make sure they're happy and comfortable. And the doctor will spend a lot of time talking to the professionals and talking to the adult that has PR. For a large amount of the time, our doctor will be asking questions about mental health. They'll be taking documentation around the child's medical history, social care history, and completing our paperwork. The child will then be taken into the examination room, which is called a clinic room. And the professional that's come along to the appointment will be asked to sit outside and stay in the waiting room for that. So although we've asked for a professional to be available for the appointment, they won't take part in the examination. They'll be asked to sit outside. And following the examination, an aftercare session will take place, and this will be a chance to go through step by step what's happened at the SARC, go through again kind of explain to the family this is what's happened here, and to go through the different referrals that need to be completed and the completion of any risk assessment, particularly the CSE risk assessments. Within the aftercare session, we give the family or the young person a summary of care booklet. So within that booklet, it documents which doctor they've seen today, which crisis worker was present, which other professionals was present, step by step of what's happened at the SARC. So if they've had a pregnancy test, if they've received emergency contraception, and document exactly what's happened there, so they can take that away and refer to it. It'll also document any follow-up appointments that have been booked in, so they've got the dates and the times written down. And it's got some useful contact numbers at the back as well, so it'll tell them who they've been referred into and how to contact them, and then some optional services that they might pick up themselves if they feel confident and comfortable to do that. We'll hand over any exhibits and paperwork to the professional, so if we've taken any forensic samples, at that point they'll get handed over, and the patient can leave the SARC. So although every child's appointment differs, and it differs in length, the average appointment usually lasts around 4 hours. And when we look at kind of the breakdown of the time of the appointment, it's only around half an hour, 40 minutes of that is the actual examination. So although 4 hours seems like a long time to be at the SARC, the examination will only last about half an hour, 40 minutes, depending on the child. It may be shorter, may be longer, and the bulk of the appointment is building the forensic strategy, taking medical history, and then sitting with them for however long it takes afterwards to go through the referrals and the risk assessments, and making sure the child and the family leave the SARC comfortable and in the knowledge that they know what's happened while they've been here, and that we feel safe them leaving and they feel safe leaving us as well. Consent. So I wanted a slide just to cover kind of the importance of gathering consent for that appointment and the examination. So like I say, the consent for examinations will always be sought from the person that's holding PR. So whether that's a parent, a guardian or local authority. Again, we prefer that in person if possible. However, it's not always possible, or it's not always appropriate. So we can gain consent over the telephone. We have also gained consent via letter if PR is being held by a local authority. And the consent from the child will also be sought and considered no matter the age of the child. So depending on the age of the child, consent can look different for the different patients. So if it's a young person, they'll be very much part of the discussions prior to the examination, and very much able to consent themselves if they'd like to go ahead with that. And then for the younger children, our doctor and our crisis worker will be constantly monitoring body language, kind of verbal cues, eye contact, behaviour changes throughout the appointment. And if at any point those change, that'll be considered and the examination can stop. Appointments and examinations will always be child focused, and it will always be led by the child. So the children that come to us would never be kind of encouraged or coerced into following through with something that they're obviously not comfortable with. And we differentiate appointment and examination. So we say that a child's present for a SARC appointment, which covers the entire length of the time that the child is with us, and an examination is the period of time they spend in the clinic room. And again, the child and the family could consent to different things within that appointment. So they might come in for an appointment and they're obviously not happy with the examination. So we can still look at kind of the holistic needs of the patient and the family. We can still make referrals for that child and make sure that they access longer term support. So each appointment is tailored very much to the child that's there in front of us, and consent is very much considered. And if, like I say, if at any point that child is struggling, we would obviously stop the examination or change our appointment so that they do feel comfortable. Aftercare. So like I say, a pack will be made up for each client, which gives a summary of care outlining what has happened, and they can take that away with them. And if there's anything that they don't understand, they can always ask either their social worker or us, and we can go through things in a bit more detail. They'll also go away with general information. So if they're not registered with a GP or a dentist, for example, we can give them information on how to do that, and a list of key telephone numbers. They'll also receive leaflets for any medication that they've been given. So if they have been prescribed Pepsi or they have been prescribed emergency contraception, they'll get a leaflet around that medication to take away with them as well. And we'd like to give the children something a little bit more fun to go away with as well. So we've got stickers, we've got pencils, we've got things like bath bombs and pamper kits. We've also got quilted blankets, which go down really well with children of all ages. So the quilted blankets will be given or offered to patients, and they can kind of wrap themselves up and get snuggly, and they can also take them home. We've also got some teddy bears that they can take home and keep as well. So a bit about safeguarding. So because of how our pathways are written, and because we encourage a STRAT discussion and we advise a professional to be in attendance at our SARC appointment, kind of 9 times out of 10, our patients are already known to social care. The 1 in 10 times that they're not, and it's a police officer that's come along and social care aren't yet aware of this child, will complete a full safeguarding referral for that child. If the child's open to social care and they've got an allocated social worker, would encourage that allocated social worker to attend the SARC appointment if they're available and if possible. And we'll do a verbal and a written handover. So we would, while the social worker's in attendance, we'll go through our safeguarding, either concerns or recommendations, and again would follow that up with an information sharing letter. And the same if it's a duty social worker that's come, we'll do a verbal handover, but we'll also do an information sharing letter to the allocated social worker as well. So again, just another stress that the strategy meetings or discussions take place prior to the SARC appointment, and we're really pushing for those. We find them extremely beneficial, not just for the SARC staff, but for the other professionals that are involved in that patient's journey as well. So a call is made 7 to 2 hours after the appointment to check that social services are aware of the patient. 7 to 2 hours is our cut-off time. We strive to do it a lot quicker. We offer a 2-week holistic follow-up with the family. So if within the SARC appointment, the family is asked if they consent to either a face-to-face follow-up appointment or a telephone appointment. And within that appointment, we will be asking if the family or the child's had timely updates with their social worker, if they've been in contact, and we will be looking at where that family's been referred into and ensuring that they've actually heard from someone within that agency. So if they've been referred into the ISVA service, for example, we'll be double checking with the family that they've heard from an ISVA, and if they've not, we'll be chasing up those referrals to make sure that they are picked up. A medical report is sent to the allocated social worker via secure email, and again, we've got a 3-week turnaround for that. And all information sharing letters are sent to the GP. Within North Yorkshire, they're just sent to the GPs unless we do know that the child is open to a community paediatrician. And these are a copy of our North Yorkshire pathways. I've sent these across to Hayden, so I'm sure he'll be disseminating them as well. But these give an overview of our acute pathways. So these are divided into children aged between 0 and 12 years and children aged between 13 plus years. And this is our non-recent pathway for children of all age ranges. But again, if in doubt, just pick up the phone and we're more than happy to guide you through the process. We're encouraging professionals to get in touch as soon as possible, and we're more than happy to kind of handhold through the entire process and make sure our child's seen. And these are a few pictures. So the way that North Yorkshire children are supported is that usually if a child's disclosed an acute offence and they are under the age of 13, they would be seen at our Hazelhurst Centre, which is in Leeds. And if a child is over 13, they'll be seen at our Bridge House Clinic, which is in York. These are photos of our West Yorkshire Clinic in Leeds, which is a brand new facility. It was only built last year, and it's extremely child focused. So these are a selection of images from our forensic waiting room and our forensic clinic room within West Yorkshire. So we've tried to make them as child friendly as possible while still being adhering to forensic standards. So everything within the rooms is washable, cleanable, and we're able to clean it to a standard which eliminates all DNA. Having said that, we have tried to make it as child friendly as possible. We've gone for a space theme in the clinic room, so we've got planets going across the ceiling and stars and things. And this is our pathway and support service number. So that's also on our pathway documents. So that's a national number. It's a 24-hour number, which is available every day, 365 days a year, including bank holidays. So if you rang during the day, Monday to Friday, you'd be put through to Emily, our strat coordinator, and she'll be able to kind of take you through the referral process. But if you did have concerns and it was out of our clinic hours, you'd be put through to one of our on-call doctors, and they'd be able to offer you either clinical advice or referral advice. And Emily would then pick up the case the next working day, or the child would be booked in. So children under 13 that have disclosed acute assaults are seen within daytime clinic hours. Our children that are 13 and over can be seen within a 24-hour clinic rota. However, the child's interest would always be considered about what's appropriate. Is it appropriate for that child to be attending in the middle of the night? But if they're nearing kind of the end of their forensic window, their opportunity to gather DNA evidence, that would be considered as well. But like I say, if in doubt, give us a call day or night, and there'll be somebody there to offer advice. And that's my email address. So I'm more than happy for people to jot that down. And if people have questions or queries or anything, then to drop me a line and I can help in any way.